Yes? I'm asking, what is neoplasia? It's a new growth. I want autonomy, yes, irreversible, monoclonal, distinguished, because I will ask what's the difference between hyperplasia repair and the tumor. All are proliferating, okay? You tell me this is uncontrolled monotonous, and it gets its nutrition from the host. This is what is neoplasia in general. Now, the second question is, what's the difference between benign and malignant tumors? I will tell you once more. If I will ask this question, this is what you will tell. But if you tell me one sentence, you will already take the big mark. It is that the benign tumors, the malignant tumors invade, give distant metastasis, they have cytological features of malignancy. These three are very, very important. Okay? You tell me this is the bigger part of the mark. Then I can come. What about the benign? They are localized, they are slow growing, they are usually surrounded. Then I will ask if they are all these good things, then what's their bad problem? You will tell me because they just compress. Okay? After that, the question will come, what are the cytological features of malignancy? Okay, hyperchromasia, pleomorphism, atypical, but please mention cytological architectural disturbance. Okay, that's very important. So the question, benign and malignant, is very common. The difference, you start, invade, distant metastasis, cytological features of malignancy. That's the base. Then continue here, tell me, localized, slow, well circumscribed, compressed. Okay? So this is question number 2. Now, after that will come the question, special characteristics. Okay, what are the tumor cells? I can ask you in general. First, please tell, I want you to, this is by heart, sarcoma, carcinoma, the two big families. Yes? I can ask you, what are the two big families? Carcinoma, epithelial, sarcoma, mesenchymal. Well, then I will tell you in general how we call the benign tumors. You tell me oma, fibroma, chondroma, etc. Give me some exceptions, or I will ask you. Seminoma, study them by heart. Okay, myeloma, melanoma, what are they? Okay. Then I have in separate. I'm asking what is teratoma, what is hamartoma. Teratoma, you will start with the word, they are germ cell tumors. Yes, the big family, you must tell me. Then you continue, composed of completely mature, at least 3 tissues that are not related to each other because each one comes from a layer endo-ecto-meso, and you tell me it is divided into benign, and it's not benign or malignant, it's mature and immature. If one element is immature, it's enough for me to tell you that this is immature. Okay? Number 2, then you will tell me, what about the prognosis? You tell me if the patient is young, I will consider it as mature and keep clinical eye on it, but if it is old, I will treat it as malignant. Now, the question again, what is hamartoma? Okay, it looks like tumor, but it is malformation. What does it mean, malformation? It means it is the same elements, but in different proportions. Okay? Now, then it comes, what is papilloma? Yeah, and what is papillary structure? You tell me, papilloma is papillary structure that is growing on the surface epithelium, composed of surface epithelium that is benign with fibrovascular core. Okay, but in general, papillary structures are fibrovascular core surrounded with epithelial cells. They can be benign, they can be dysplastic, as we studied, or they can be part of invasive carcinoma, which means that the invasive elements have the shape of finger-like. Okay, this is important. Papilloma, benign tumor of surface epithelium, composed of papillary structures, but covered with benign epithelial cells. What is papillary structures? Fibrovascular core surrounded with epithelium, grossly again finger-like projections. Okay, you tell me they can be benign, dysplastic, or part of invasive carcinoma. Okay, now I can ask you also what is adenoma. Okay, adenocarcinoma, you know all this. Now, till here any questions? No. Now, we say the exemptions, these are there. Okay, psychological features, we said it. Now, what is differentiation or grading? The same question. Yeah, you can answer from any place, but you just can answer me what is grade of differentiation, how much the tissue resembles, please, cytologically and architecturally. I want this answer. It's not written in purpose. I want you to listen to me. Yes? How much does it look like the mother tissue cytologically and architecturally? Which means adenoglandular structures, squamous keratin, okay? So that's very important. According to that, the benign tumors, you tell me they are completely well differentiated. While the malignant ones are either well, moderate, poorly, or anaplastic, they are not differentiated anymore. Okay? So please tell me, how much does it look like the mother tissue cytologically and architecturally? Again, well, all benign tumors are well, malignants are well, moderate, poorly, or anaplastic. Okay? So here I can ask you, then you have a squamous epithelium, a squamous cell carcinoma. How you will give me the differentiation? Okay? What you will tell me? Keratin. I will tell you, if I have adenocarcinoma, how you will give me the differentiation? You tell me glands. Okay? I will ask you benign tumor, you tell me any benign tumor is well differentiated. These are questions I can ask. I can ask it with pictures. Okay? These are small questions. Okay? It's very important. So when I will write well, I will look cytological features of malignancy. Atypia, I will see a structure which is glandular or squamous or whatever it is. Okay? I want to take complete mark, you will tell me this cytologically and architectural. Now, another question. What is the microscopic features of the tumors? Now, let's come here. Now, before you start telling me what does it mean microscopic features, this is I want to explain. It means that you have a microscope, you put the slide, how you will walk. Yes? Before that, you will tell me any tumor, benign or malignant, it has two components. Parenchyma, which is the proliferating, the stroma, which is the supportive one. Okay, then you start. I put the slide, the first thing what I will look, architecture, pattern. Okay, which means you will tell me, is it gland, is it nest, is it fascicles, what do you see architecturally? Yes? And in the architectural part, you will tell me these pathological changes, in which level do you see? Why? Because you will decide, do you have invasion or not? This is also, I haven't written, I want you to answer. Okay, again, so number one, microscopic pattern, what I will look for, this architecture. Number two, where is this? In which layer? Okay, because which layer will decide me, do I have invasion or I don't have. Okay, please add this. Number two, histomorphology of neoplastic cells. What does it mean? I will look for differentiation and neoplasia. What is differentiation? Cytological features and architecture and glands or whatever it is. Okay? Number three, I will come now to the stroma. What I will look in the stroma? Tumor angiogenesis and the stroma. And again, I haven't written out what do I see in the stroma in malignant tumors? Necrosis. I see hemorrhage in both. These are changes, myxoid change, hyaline change, whatever it is, I must mention. And at the end, it's very important for me to mention inflammatory because some tumors, the prognosis depends on how much inflammation I have in this tumor. Okay? Again, this question, how you will answer to get the full mark. What are the microscopic features? You start. Any tumor, benign or malignant, has two components. What is parenchyma, what is supportive? Now, I put the slide. Number one, you tell me microscopic pattern. What does it mean? It means acini, sheets, column, okay? Solid, papillary, everything you see in the architecture you must mention. Plus, mention it where? Because at the end, when you will write to me it is invasive, I must read there, yes, you have seen them in dermis. For example, these epithelial cells. Okay? Then I come to the cells. Histomorphology of the cells. What does it mean? Differentiation, neoplasia, cytological features of malignancy, and how much they resemble. Do I see glands? Okay, do I see keratin pulse? Okay, for example. Now, number 3, I come to tumor in the stroma, angiogenesis and the stroma, hemorrhage, necrosis, hyaline change, mucoid change, whatever I know. And at the end, I will write inflammatory reaction. Any questions? This is important. Okay, this is the basic part I'm asking, and I will ask tomorrow, I will ask in exam. Now, I will come before carcinoma, I ask it in dysplasia. What is dysplasia? Now, if anyone forgets what I have written, please remember this very simple fact about dysplasia. I told you what is malignancy, cytological features plus invasion. Yes? In dysplasia, I have cytological features, no invasion. Okay, you just tell me cytological features without invasion. Okay, or irreversible, this is when it is high grade. Yes, in the low grade, sometimes if it is viral, as I said, they changed it now, it can be reversible in the beginnings of the viral. But once I move to moderate and severe, finish. Okay? Change affecting focal area without invading of the basement membrane. Okay? Pre-malignant change, what does it mean? Cytological features of malignancy. Okay? Or disordered growth that is cytologically malignant. That's very important. Okay? Now, according to this, I will have 3 types. Mild, moderate, severe. Why I want you to understand, to see that it can affect only the lower, it can affect the two-third, it can affect all layers. Now, they call it low grade, high grade because they saw for the prognosis. They saw that the low grade sometimes goes to normal if it's viral, okay? But if it is moving to more moderate and severe, no way back. And some doctors, the severe one, they call it carcinoma in situ. So when I ask you what is carcinoma in situ, you tell me this is high-grade dysplasia or severe dysplasia without invasion of basement membrane. Okay? Is it clear, this dysplasia? It's very important. It is why it is pre-malignant, I can ask. You tell me because it has cytological features of malignancy. Okay, you cannot ignore these features. Always remember the 1 plus 1. Cytological features, invasion, distant metastasis. Okay? No cytological features I have benign. Only cytological features the dysplasia. Cytological plus invasia I have invasive carcinoma. Okay? I want you this base, this year you must know. Okay? Because on this we will build what we are going to study next year. Okay? Any questions? Okay, dysplasia is pre-malignant, but does not necessarily. It depends on other factors. But again, you cannot ignore it. Because the tumors, as I said, they are unpredictable. You don't know if they will go or they will not go. So you take the safe side. Now, I say this. Now, the question, when it comes to what are the spread of the tumors, we already know what does it mean. Number 1, invasion. Number 2, distant. So the benign tumors, as I say, they don't invade, they just compress. Okay? The benign tumors are encapsulated or circumscribed that expand. Expand means only compress and push aside the surrounding without actually invading, infiltrating, or metastasis. Okay? So when I say spread of tumor, it starts with the benign. Tell me the benign, you know, they are encapsulated, they just compress. They don't invade, they don't give distant metastasis. While the malignant one, they invade. What does it mean invade? It means infiltration and destruction. That's it. What does it mean metastasis? It means distant metastasis. Okay? So local invasion is destruction. Distant metastasis, then I will ask another question. Okay? So for the malignant, what's the answer? The malignant tumors invade, which means they infiltrate, they destruct. This is the first step, which is called local invasion or direct spread. Okay? Local spread, when it breaches the basement membrane, they go down, they start. Okay? Once they are up the basement membrane, they are in situ or severe dysplasia. Once they break, I have local invasion. Okay, they start destruction and infiltration. Now, how do they do? Detachment of tumor cells from each other, attachment to the embryo, degradation, and migration. Now I will do the distant metastasis. How do they start? Okay. You can study by pictures. Okay, how they are. This is inside. Invasion, the first layer, the second layer. Once they invade, they will infiltrate like a bulldozer. They will walk. Okay? They will destruct, they will invade, they will walk direct in the area. They will occupy all the area with all the layers. Okay? So, now squamous cell carcinoma is just a picture. In the pictures I will explain tomorrow. This is the adenoma, I will explain tomorrow. Now, I come to the metastasis, distant metastasis. From here, what does I want? I want you to remember that we have several routes, yeah? But the preference goes to lymphatic and hematogenesis. Usually carcinomas lymphatic, while sarcomas hematogenesis. Okay, the lymphatic will go to regional lymph nodes, and the white bloods, they can go anywhere, but they have preferences like liver, lung, bone, brain, etc. Okay, you gave me two. So again, metastasis, distant metastasis, they have some rules. They bust, aeroplane, etc. Okay, the most preferable one are the lymphatic and hematogenesis. Lymphatic will go to the lymph nodes, hematogenesis anywhere, but they have some preferences. Now, once they arrive there, they start, one cell is enough. They start to proliferate and invade, and it can give another metastasis also. Okay? Now, another one, how do they do that? You can explain the picture. Okay? Extravasation. They enter, travel, intravasation, travel, extravasation. They arrive to any part, if it is lymph node or it is liver, whatever it is, and they start proliferate, and the circle turns. Okay? Any question? These are pictures for how intravascular, okay. Now let's do it again, because I don't want you to study everything, but I want to tell you what I want exactly. Let's start, okay? Spread of tumors, this is a question. Yeah, how you will start? You will start benign tumors, they don't invade. Remember the 1+1. They don't invade, they don't give distant metastasis. What do? They expand or compress. Finish. I come to the malignant. The malignant, you will tell me, they invade, they give distant metastasis. What does it mean, invade? How do they do? Invade, infiltrate, and destruct. And what does it mean, distant? Distant metastasis. Start with number 1. Direct spread or local invasion, it's the break of the basement membrane. Once they break, remember the bulldozer, they will walk, invade, infiltrate, and all the area will be occupied by the tumor. All the layers. Okay? How do they do detachment? Attachment to the extracellular matrix, degradation of extracellular matrix, and migration. Now, this is a picture, you can tell me, just a picture to remember. How do they do it? The penetration of basement membrane and bulldozer walking. Okay? Now, I come to the distant metastasis. You tell me, distant metastasis, they have roots. What are the most preferable one, lymphatic or hematogenesis? Now, this is the carcinomas prefer the lymphatic, the sarcomas prefer the blood-borne. Now, in both, the first one goes to lymphatics, the second one anywhere you can predict, unpredictable. But they have some preferences, tell me 1 or 2. How do they do? You explain me the picture, okay? Intravasation, okay? They travel, extravasation, and they migrate, and they start to proliferate. Now, grossly, how do they appear? Microscopically, how do they appear? Grossly, usually, remember, when you will send the picture to CT scans, okay, you will see small and multiple. It can happen, okay, it's not general. This is what I'm talking you general rule, but they can do anything they want. Well, okay, but generally they are small and multiple in the blood-borne ones. Of course, the lymphatics will be big, but again, enlarged lymphatics are not always metastatic. That's why you send us, because it can be hyperplastic reactive. Okay, and structures they can mimic the primary tumor. Usually, they have the same differentiation or less. Okay. Any questions? Tell me. Now, when I will ask prognostic indicators, okay, you tell me clinical, or you ask me this molecular or immuno. Let's start with the clinical. What is important for you? Remember the T and M. Once you remember this, you will answer. T, tumor size. Tumor grade differentiation. Okay, which means histological grade. You will tell me, you will send me N lymph nodes. You will tell me we have distant metastasis or no. Okay, so these are all in the clinical. Again, clinical, remember the T and M, size, metastasis, lymph nodes, and very important, grade. Because remember, in the T 1, 2, 3, the size, it is also related with the differentiation. Okay? Now, molecular, just choose one or two and tell me which one do you want, because this is we will study next year. Each tumor has its specific one. Now, what is grading? What is staging? The last question. Grading, I have explained. You take it from there. How much do they look like the mother tissue cytologically and architecturally? Well, moderate, poorly, severe, anaplastic, okay? And this is about the grading, and remember the grading, I will give it to you. Now, what is a stage? A stage means how much it is spread. Now, it will be on clinical basis. What does it mean? It means that you will send me the lymph node. I don't know. You will send me the metastasis. You will send it to me to confirm what you already clinically suspect. Okay? So, according to the staging, it is the most common one you will read in our reports. It is T and M. The T is the size, I will give it to you, okay? And of course, always remember, before T, when I will write you the diagnosis, I will write the grade directly, okay? Then I will come to the T, which is the size. The N, it is the lymph nodes, the number of the lymph nodes involved, and M, if you sent me biopsy of the metastasis, it was near, I call it M1, it is distant, M2. Now, the second system, it is AHD, it is depend on metastasis and the size of the tumor. They combine it, okay, something. Tumor to the site of the origin, it is locally invasive, cancer spread to regional invasion, okay, cancer spread to distant metastasis. This is something in general, okay? But the TNM is very specific. Usually they do both, but they depend very much on TNM to come and give this staging. So the first important is the TNM. Okay? Any questions? Okay? Well, tomorrow I will explain the pictures, and I can do this quickly also. All right? Any questions? You can go. Good luck.